I'll give the first talk telling a little bit about the West Nile virus neutralizing plasma study that we carried out here at Sheba. And the SPRI, as we've said in previous seminars, this is actually the 6th seminar of SPRI. Our idea, our vision is to implement basic science and translate actually basic science, epidemiology studies, immunology studies into a clinical product. And for that, we established all these cohorts, the different cohorts, where we look at people who were exposed to different potential pathogens. And one of these projects is the West Nile virus project, which actually started back there in December 2022, way before this last summer and all of what happened during that time. And as we started this summer in June, when we were already at the phases, and all of this you will hear later in the next session, and part of it by Ted, by Yaniv, and Danny. We were at the stage in the beginning of the summer where we were just about to have the mouse experiments at the NIH to develop a monoclonal antibody for West Nile virus. And at that point, we started to understand that we have a problem. And what can we do? We see this increase. This is the just initial epidemiologic curve of the West Nile cases just here at Sheba. 27 cases per week. That was extreme. That's typically 1 year in all of Israel. And again, Sharon will talk a lot about that. I'm not going to speak about that, but that's the stage where we said we have to do something. And we just were dreaming of how we could have done if we had our monoclonal ready for a clinical trial. But unfortunately, that was not the case. And we had to think a little bit creative and say, what do we do? So we said, okay, why not use the plasma from the healthcare workers that we already at that stage knew that some of them had high neutralizing titers, but let's do it properly. Let's run a randomized double-blind clinical trial. And we thought at that stage that if we have 20, 30 patients per week just in Sheba, we can easily recruit 100 people by the end of the season. And we did the power calculations with 120. We're really good. Let's ask some other hospitals to join, and maybe we can run a multi-center study. Eventually that didn't happen, although it was nearly there. Just to show the timeline, on June 27 was the first time we sent healthcare workers a letter telling them we need plasma from people who have high neutralizing antibodies. And the first recruited patient who came in with West Nile was in July 4th, 1 week. And what did we do? So we asked the people, and yeah, well, you were there. We asked people, all the healthcare workers, to come and test for West Nile. And people were really standing in line, coming to assess whether they have West Nile. And we found about 12% of the healthcare workers positive for West Nile antibody. For them, we tested for a neutralization antibody using the knowledge that we achieved through our collaboration at the NIH. And our inclusion criteria for donating plasma was one, it had to be either a man or a woman before ever being pregnant because of antibody issues when you donate plasma. So we found these with, and initially we took anybody with neutralizing antibodies. At some point we decided we'll just try to take those with high neutralizing antibodies. And as you'll see in a minute, we learned what it is. And yes, Professor Kreis was one of the first donators of the plasma. So what did we do? We ran a randomized placebo-controlled double trial to test highly neutralizing West Nile plasma. We screened the patients that came into Sheba, and you'll hear a lot about the patients later in Daphna's talk. And we, whoever agreed, we recruited and agreed, then we gave a 2-to-1 randomized, although you can differentiate between plasma and cell line easily, it was in a black bag, so it would be double blind. And the study schedule was initially, we included, the inclusion criteria were anybody who was hospitalized, age 60, or it could be younger if he was immunocompromised. And he had a West Nile diagnosis by either PCR or IgM within 72 hours, within the last 72 hours. And the symptoms could be anything, but he had to be symptomatic. So either fever or neurological signs. The follow-up was on day 1. We initially randomized for placebo or plasma and gave him gave him or her the treatment, and then we assessed, and the neurologist, I didn't see if they were here, if they are here, but they really helped a lot, and they assessed every one of the patients initially on day 1, and then in the follow-up, we tested for cognitive functional assessment, and we tested the viral load in the blood and in the urine, and if possible in the CSF as well. Then the follow-up was on days 3, 5, 7, and 14. Again, these neurological assessments and the viral load, and the end of study and the outcomes were, the primary one was on day 30, any unfavorable outcome, and which we defined as mortality and functional deterioration. And on day 20, a secondary outcome was, first of all, mortality, but then we had other secondary outcomes like neurologic, cognitive, functional, each one separately or a composite outcome. Okay, and the statistical plan was a logistic regression. The exposure was modeled either as placebo versus plasma versus placebo, or categorically looking at high neutralizing, low neutralizing, or placebo, or as continuous, looking at whether each log of increasing neutralizing antibody will matter. And the outcomes, as I said, a composite of bad outcome at day 30, and then secondary, either mortality, the Glasgow Coma Scale, mini-mental, or Bartel, which is ADL or functional capacity. And we also assess ICU, ventilation, and so on. So I'll just give you now the preliminary results, which really, we opened the study about a week ago, so it's very preliminary, but these are very impressive, I think. So we started with 38 recruited. We didn't get to the 100 or 120 that we expected, and that's why I was actually surprised that we have any results which are significant, but we do. And among these 38, because the outbreak, and you'll hear about that from Sharon, I think later, of how the outbreak went, and it didn't continue for a very long time, fortunately. And so among these 38 recruited people, 3 did not have available B or AB plasma, and that was in the initial phases. Later, we had enough healthcare workers that donated blood, so we didn't have a problem, but initially we did. And we had 1 that eventually had West Nile diagnosis 2 months earlier, and he had to be excluded. So we had 34 included, 12 in the cell line, 22 who got neutralizing antibodies. And if we look at the titer of the neutralizing antibodies, we see that this is the group who received 0, who received the cell line, and these are the groups who received different neutralizing antibody. Of course, every plasma that was donated had a different titer. So this is what we had, and we sort of split it arbitrarily in a way, or maybe not exactly arbitrary, but above 1,000, we called it high neutralization, and below, we called it low neutralization. And so what did we see? First of all, the study population, the median age is, as you see, most of the patients were above the 70s. Women and male were pretty much the same. And we had about a quarter or nearly a third of the patients who had immune deficiency, mostly B-cell immune deficient. And again, on that, Daphna will talk a little bit later why this is important. And the time from symptom onset until when we got them was, the median time was 7 days. So we had about 50% of the people, or maybe slightly less, who came early enough within 5 days, and 75% or 63% who came up to 1 week after symptom onset, but some came later. Okay, and safety is one thing we checked. There's nothing really special to say about this, but there was a single case of allergic reaction, and we, of course, reported all the SAEs. All were related to the disease deterioration, any death, and so on, and there were deaths in the group. So what are the results? The major result is mortality, and we can see that the patients who received saline had 35% mortality rate compared to those who received plasma, where it's about 10%. There were just 2 patients here. And if we look at we compare low titer, high titer, and saline, in the high titer, where again, 11 patients, it's small numbers, but still you see that it is significant, none of them died. In the low titer, 2 people died, and in the saline, I think it was 5 people who died. So this is obviously very impressive. Then we tried to stratify by the immune deficiency status. And if we look at the immunocompromised patients, they had over 60% mortality if they got saline. And this was very dramatic with the plasma. Less than 20% of those who received plasma died. And in the non-immune deficient, still it's significant, and the rates of mortality obviously are lower. And as you can see, when we adjust, we are talking about an 8 times decrease in mortality. It's very, very impressive. And this is not statistical, but just to look at the survival of the patients. Of course, we need larger numbers, and still the follow-up is, I think, very interesting. Other outcomes that we looked, and again, we defined, unfortunately, our primary outcome as a composite outcome of Bartel, which is any minimal neurological deficit that the patient had. If he's not back to totally normal, we would call it a bad outcome. And that was eventually probably not the smartest thing to do, but we learn. And in that, we didn't see any difference. So there's no difference in that. But again, if you look at the mortality among these, that explains a lot of it. The only other significant outcome among the secondary ones that we assessed up to now, we're still, again, analyzing some of the data, was the consciousness. And these are the final results. So what you can see here for death, for example, is that for every log of titer of neutralizing antibodies that you give higher, you can decrease or protect the patient by 12%. So this is very, very impressive, these results. Also for the consciousness of the patients. And the limitations are that we had a small, obviously, sample size. We maybe need a longer follow-up, and some of the outcomes were probably not subtle enough. I have to say that obviously the logistics of such a study, as maybe you've understood a little bit, were very, very complex. I don't know how feasible something like this is in the general population, but I think that we have other solutions. That's what we're heading for, which is the monoclonal antibody. So the conclusions from the study are that neutralizing plasma given to patients with West Nile virus, mostly it was neuroinvasive disease, within 72 hours of diagnosis and within 7 days from onset of symptoms was associated with decreased risk of mortality. We observed the dose response effect, which is really important. The higher the neutralization antibody, the more the protective. And about 50% of both groups had functional deterioration at 90 days. It's really a bad, severe disease that we need something to help patients to protect them from. So neutralizing monoclonal antibodies could be useful for treatment and prevention. And that leads us to the next session later on that we'll hear. And there are really a lot of people to acknowledge. all of the physicians from the infectious disease unit, and of course, Daphna, who is my collaborator in all of this, and her group who went and recruited all the patients, Yaniv, and you see Sharon, I know to put MOH there, and his group who really did a lot. I have to say the blood bank, I'm not sure if they're here, but really different hours that we asked them, they were there for us. Also the central blood bank in cases that we didn't have B plasma. The neurology department, internal medicine department, which some of them I see here, really helpful. Everybody was just so much devoted to this that it was really exciting. Of course, my group, the microbiology group, infection prevention and control, my nurses, and I have to, of course, say thank you to the Sheba management, not just for donating that blood and maybe saving one person, but in general for all of you, what you're doing. And of course, the NIH, our collaborators, which really, I think the future from this is going to be even much more exciting, and we'll hear about that later. So thank you all very much. Questions? Yeah, Ellie.
I wonder, I mean, excellent results, and I wonder whether you, no doubt that we want to produce now monoclonal antibodies. Is it going to be ethical to do randomized study?
With the monoclonal antibodies?
Yeah. After having so...
Yeah, I think we have to, because it's a new drug. There won't be any way to get out of this. I would say that I expect that the monoclonal antibodies won't be in the coming season, probably only in 2026, if I want to be realistic. And then in the coming season, if we have another outbreak, I would try and give this kind of plasma just as compassionate use, which will make things easier in the meanwhile. But
I think that the only solution might be plasma versus monoclonal and not versus placebo.
But monoclonal, once we have monoclonal, I see what you're saying. When you have yeah, I see what you're saying. Interesting. Yeah, yeah. I think we won't have. We'll have to put a placebo. Yeah, we'll have to have placebo. But we'll talk about that actually later. So yeah, Michal.
How do you explain the effect on mortality without an effect on neurological deterioration?
Because
the majority of the patients died after severe neurological deterioration.
I agree, and we looked specifically, and the problem is that we put the outcome, and that's what we assessed as Bartel under 90, which means any slight thing, and we know we put too high of a, we need much subtle, more subtle changes in the neurological assessment, and then I'm sure we can see other things, because we know that we saw the patients. And also maybe the duration, because we had now just one patient who was concluded as a bad outcome because neurologically she was not fit yet at 90 days. But just a few days ago, Shiraz knows, she sent you, or it was really, we started crying there. She said, I have to tell you, I'm all right. And she sent us, I don't know if it was just a WhatsApp and her picture, or she talked to somebody in the group. But I think maybe it takes a long time. It's really a very bad disease. That's my main. And I think we just didn't put the outcome correctly. That's the thing.
But you have all the primary data. You couldn't.
We can, and we will.
Yeah,
that's what we'll do. Again, the primary outcomes that we set and we wrote in the clinical trials, we'll have to report that. But we'll look at more than that. You're right.